So my presentation is going to be like more focused on the application of neural interfaces. That neural interfaces can go from the use of identity EMG and EEG or any other tool that can be used to record information from the human body, and then we can use that information in order to interface the nervous system, in this case, to try to manage the symptoms of movement disorders. So this is like the general overview of the presentation. I will start with some basics of neurophysiology and motor control that at this point of the summer school, you should all know about it. Then about some examples of neural interfaces in operant conditions, human-machine interfaces. And then like a few examples of management of pathological trauma, which has been my main research focus in the last few years. And finally, another two like more related to the use of high density EMG that we recently presented, and maybe could expand it and use more in different styles. So sorry about it. So this is my career path. I'm still considered a young researcher according to HybridNeuro, but on July the 15th, I think it's Sunday, I'll become a qualified scientist. So my talk and my cachet will increase when giving talks. But my background is biomedical engineering. So I did my master's and bachelor in Madrid, in Universidad Politécnica de Madrid, my PhD in CC, in the neural rehabilitation group, which was a group more focused on the use of exoskeleton and neural interfaces rehabilitation technology applied to rehabilitation in stroke, spinal cord injury. And my thesis was mainly focused on the use of electrical stimulation to reduce pathological trauma in essential trauma patients. Then, a couple of years ago, I moved to London to work with Dari Farina, his group. I've been working there, like doing maybe too many things at the same time. And I'm glad to say that I will join the Jaime Ibanez group in the CICOS in Zaragoza with Marie Curie starting in January. So let's start. Like this is the slide I think I have in my presentation since always. We know the central nervous system like send efferent commands, but most part of the time we forget that it's not just unidirectional system. We have complete flow of afferent information coming back to the brain, and not only to the brain, but to the spinal cord. So there are multiple centers that integrate information and are actually working full time in producing the motor command, adapting the response, and then achieving the final motor control. So when we have a neural disease, a neural injury, such as a stroke, can be pathological trauma, Parkinson's disease, a spinal cord injury, there are some abnormalities, and these circuits stop working in the way they should be. And what we can do is trying to compensate that with the term like used here, like it's neural interfaces. So we are going to record information, neural information from the brain or from the periphery. We are going to use that information in order to try to stimulate the nervous system and see if we can revert the abnormality in the functional or the functional outcomes, so the patients can improve their quality of life. I think this is one of the best examples of neural interfaces and the most advanced state-of-the-art we have in Cook Team Group. So this is the full closed-loop system going from the cortical implant that it's able to record electrocortical activity from like the motion intention. So you can detect when the subject wants to actually move. And then you have a full closed-loop system based on identifying the motor intention. And you have an implant in the spinal cord. It's called epidural spinal cord stimulation that actually recruit the afferent fibers and the motor neurons in their pathways in the spinal cord, and that allows the subject to actually walk. And these are like tetraplegic subjects, so they have non-residual function, and while they are receiving like this assistive therapy, they are able to walk, and they were completely unable to walk before. So this is the farthest we've gone. And now here I'm going to present another example that it's maybe more feasible. It's a project that many partners in this room, like Silvia Mucelli from SSIC, Fraunhofer Institute, the one producing the intramuscular electrodes, we will present in tomorrow sometimes, Imperial College London. So this was a project that had the aim to use like implantable EMG and stimulation electrodes that actually were capable of be just powered up by external power supply, so completely wireless. And the final goal was to have like different set of these implants, and that would allow different applications. One of them, the control of wearable robotics. For instance, if you can read the EMG for multiple muscles in the leg, maybe you can have a closed loop system to interface with an exoskeleton and provide a more natural walking pattern. And this is like what was the final goal of the project, and they went very close. Like these are the bionics implants that were in the state of the art. They are rigid, so you need a surgery to implant and explant them. But these ones were minimally invasive electrodes that could be just injected to the subject with camera. So now we move to the movement disorders, which are those group of neurological conditions that actually cause any kind of abnormal involuntary movements. And there are different causes. And some of these movement disorders can be qualified as hyperkinetic. So there's an excessive movement, obviously unintentional. We have tremor, which is the rhythmic and voluntary activation of the muscles. It can be like produced by two main diseases, essential tremor or Parkinsonian tremor, Parkinson's disease. We also have chorea, such as the Huntington's disease chorea, which is like abnormal rhythmic movements. I don't know if you've ever seen a video, it usually affects children. Then we have dystonia, like mainly affecting cervical dystonia, which is involuntary movements in the neck. So they tend to go to one side and they cannot control it. And then we have myoclonus, evaluations, ataxias, and many other like movement disorders. In the epigenetic disorders, then we have Parkinson's disease as the main disease, like causing these kind of syndromes, which is characterized by bradykinesia, rigidity, and also rest tremor. And finally, like a different category, like spasticity, which is the increasing muscle tone that when the subjects try to move, they cannot because the muscle is really rigid. And when you try to move it like passively, it's hampered by the speed of the movement. So these patients are really hampered when doing any kind of activity. So now we will start with some basics of neurophysiology and motor control, probably at this point. I'd say you know all of it. So in this summer school, we are always focusing on the motor neuron level, so mainly the alpha motor neurons that are projected to the muscle, so they receive the supraspinal input, mainly from the corticospinal tract, and they, like as a motor neuron pool, they transform those cortical inputs as a linear transform, and then you have like the common input transmitted to the muscle that allow us to generate force. But we forget that this is just the supraspinal corticospinal tract that it's receiving the alpha motor neurons. But if you go up to the brain, like that corticospinal tract, it's actually much more complex because it's receiving a lot of projections from different brain circuits and that are not the cortex, such as the basal ganglia or even the medulla. So my message here is that when we look at the results, we are just accessing to the final output here. But when you actually are trying to understand why that's happening, we are missing a lot of information that it's relevant and it's key in neural diseases, such as Parkinson's disease. This is where the problem is happening. So we will try to detect those changes in the periphery. And it's a challenging task. Now going back to motor neurons, just in case, I don't know if this information will be useful, but we have alpha motor neurons. They innervate like extrafusal fibers, which are the ones responsible for force and the ones that are studied with the EMG. But they are large in size, they have higher condition velocity, but those are not only the only motor neurons that we have. So we all have gamma motor neurons, which they innervate intrafusal fibers, which they do not contribute to the force, but they are really important because they are able to measure, to change the sensitivity of the muscle spindles, which are like one of the main afferent pathways involved in proprioception. So when we talk about motor neurons, I just want to say that we are always talking about alpha motor neurons in this talk. And we forget about gamma motor neurons because we cannot report them from the periphery, from EMG. Their behavior in humans is not so well studied. And then we have beta motor neurons that we don't know much about them, but should be a mix of the properties of these two. Then, at this point, like we know a motor neuron or what it is, a motor unit, and we have three types of fibers: slow, fast fatigue resistant and also fast fatigue fibers, like each one with different properties. And I think now it's the first question to see if you've been actually listening to the past talks. I'm going to start a Kahoot. So please join now and don't close the tab in your phones until the end of the presentation. So, I mean, I'm trying to play the trick here to just keep your attention for the whole talk and see if we reach the end without losing anyone. So please join. I have to say, who is John Cobra? Okay. Yeah. Sorry. I think we are ready to start. I have to say the questions are quite simple, so everybody wins. So at this point, I hope everybody can keep the right question here. So, which is the recruitment order of the motor neurons? Seriously? I think maybe we need to repeat like some of the talks from the past debate. So let's go back to them. Sorry. So we have to go back to the HNI24 principle and the order of the motor units. We start with the slow fibers, and then gradually we recruit the fast fibers that are fatigue resistant, and then the fast fatigue fibers. This recruitment order is based on the size of the motor neurons that are located in the spinal cord, and it's related to the size as well because of the resistant and conductive and conductant properties. And the way you sample the synaptic input from the cortical spinal tract in this case. So please, like, we start always repeating the slow fibers that produce the low force, and then we start adding motor units that can fire at higher forces, and they are also more sensitive to fatigue. Then we go back, and if we have like alpha gamma motor neurons, we have a whole set of sensory fibers that are sensing all the time what's happening in our body. We have many receptors in the skin, giving us information about pain, temperature, pressure, touch. But I'm going to I want to highlight like the muscle and skeletal mechanoreceptors that are used to induce proprioception, which is the way our body is able to tell us where our body is. Our body joint, our muscles are located, so we can actually move. Without proprioception, that would be like not really possible in a healthy way. I want to highlight like the muscle spindles, which are the ones sensing like the muscle lengthening, and they are connected to the 1A fibers, which are sensory fibers located in the spinal cord, and these are along together like the Golgi tendons that muscle force tension, like in the tendons. Those are the most important afferent inputs that motor neurons and upward projection in the brain. There are other fibers that I'm not going to to talk about, but I just want to you familiarize with these two because they are important in what I'm talking about later, which is the spinal cord circuits. And we will start with the simplest one, which is the stretch reflex. It's called H reflex when you elicit it with electrical stimulation. So we have the muscle spindles that are located in the muscle fibers, and they're able to measure, and they are sensitive to the muscle lengthening. So if the muscle is lengthening, the firing rate will increase, and it's a way of coding for the status of the muscle. That information is sensed by the one fibers that are located. Actually, this is not correct. And then it has a synaptic connection with the alpha motor neuron innervating the same muscle. So this is a protective mechanism that's what it's called the stretch reflex. And I think the best example of it is when you hit your tendon here below the patella, and you have this reflex toward using it. So that's a protective mechanism that when the muscle is suddenly stretched, it will try to contract to prevent damage. And we can actually bypass like the tendon top by just stimulating the afferent fibers. For instance, in the median nerve here around the elbow. So if we stimulate, we can actually recruit the afferent fibers and also the motor neurons through the motor axons. And what happened? That usually it's the theory, but in the practical, it's not always easy to achieve. Like the afferent fibers have a lower threshold, so you recruit them first, and you produce an action potential that propagates to the fibers, reach the motor neuron, and then produce an action potential in the motor neuron, and then you have like this action potential called the H wave. So this is the wave that is produced when you stimulate the one afferent fibers goes to the spinal cord back, and you have this wave, this action potential. At the same time you produce the stimulation, you also have the direct response, if the stimulation is high enough, that will depolarize the motor axon, and you have this M wave response. So in time, as you see, if you have first the M wave, and in the meantime, the other reflex loop is charged to the spinal cord and back, and you have the H wave. And this is a very useful tool that has been used in neurophysiology. And it allows us also to understand some of the mechanisms underlying motor control and some basic circuits. These are two of them, like reciprocal inhibition. Maybe this is the most important to understand part of my presentation here. So this is a encoded mechanism in the spinal cord that allows to inhibit the activity of the antagonist muscle. So the active contracted muscle can easily exert the force and perform the movement. So if we have this one afferent fiber, so this muscle actually, when it's activated, it can change and inhibit the activity through this one into interneuron of the antagonist muscle. So this allows us to have like flexion, extension in simple joints such as the biceps or triceps, in the soleus and the tibialis, to have like this flexion extension movement. So we have activation of one muscle and relaxation of the antagonist muscle. Another example is the 1B inhibition, which is just the opposite. So if a muscle is contracted and it's receiving a lot of tension, so that's measured by the Golgi tendons. So if the tension is too high, there's going to be a mechanism trying to protect the body from damage, the muscle and the tendon. So it's called autogenic 1B inhibition. This is a very simple circuit. In practice, then it gets much more complicated. But we have an inhibitor interneuron that actually inhibits the homonymous muscle. So these are two basic circuits located in the spinal cord that they are protective reflexes, but they're also involved in many other tasks. So we have a next question. So second question, are the spinal reflexes hardwired circuits? 50% chance. More or less like random distribution. So no, like they are not fixed hardware circuits. They can be adapted to different behaviors. Otherwise, like we'll be jumping just because of the such as a cat, for instance, like that tend to have like hyperreflection. And there's a disease in cats that when they have, probably you've seen it, some stimuli, they just jump and they cannot control it. But we are not like that. And this is one of the examples I'm going to show. Like, for instance, if you are holding you are holding yourself to a table and you are in a stable position and you are using your hands to stabilize, if you get a perturbation in the other side, like what is going to happen is your arm is going to contract and trying to stabilize your whole body under that condition, because the priority there is the stabilization of your body, not to fall. But what happens when you reprogram your brain and then your goal is not longer to not fall, but you have something else, which is like you are holding a math and you don't want to split the content, What will happen is that the arm that was holding the math, like now it's not going to contract in terms of like achieve like maximum stability, but it's going to stabilize the arm in order to hold the math and not fall down. So probably your whole body like will change the activation patterns of this reflex, which is not only spinal, this is also like supraspinal reflex, but it's going to try to change everything to prioritize the function, which is don't let the math like fall to the floor. And this leads to the next concept, which is neuroplasticity, which refers to the capacity of the nervous system to modify itself functionally and structurally in response to like learning experience or also brain injury. And how this is achieved in very general overview through the Hebbian plasticity mechanism. So when you have repeated pair activation of a synapse as a circuit, leads to plastic mechanism. So you have a neuron, and when it receives like two inputs at the same time, and those are considered like a positive feedback, you are reinforcing that circuit, and that's what leads to plasticity. It's like positive reinforcements in learning. So we can use this tool in using neural interfaces to actually increase or decrease the excitability of given circuits that will provide neural adaptation that hopefully the final goal is to actually have some implication in the functional outcomes. And I'm going to show like the work, the theory proposed here by Walpole and Casimir, which are related to that spinal circuits are not hardwired behaviors. They define the concept of hexor like a widely distributed network of neurons and synapses that produce an adaptive behavior and change itself as needed in order to maintain the key features of a behavior. And I'm going to explain that concept because it's important to have a general overview and understanding of how our motor control is kept during time when we learn new tasks. So imagine like in this circle, the triangles represents like synapses or neurons. If you have like a preset circuit, for instance, like this withdrawal reflex, if you are, I don't know, like hitting something like that it's painful, you will have a withdrawal reflex that it's automatically encoded in the spinal cord that will prevent the foot to still hitting that nociceptive input. You will withdraw it, and this is the reflex that is happening. And it makes use of a given number of neurons in the spinal cord or the overall like central nervous system. What happens when you actually learn a new behavior, such as walking? That walking is also, because you use your legs and many muscles in the body, and many afferent circuits involved in proprioception and gait. You are using also those circuits, and while you are learning, you are adapting those circuits, and you are modulating them, and you are optimizing them to perform the task, which is so-called the hexor. So you are learning this new task, while at the same time, you have to preserve the key features that allows you to actually keep this withdrawal reflex. So the synapses, the neurons are able to sample like multiple inputs, and depending on the input, they're able to respond in one way or in another way in order to keep two behaviors. The moment you start adding more and more behaviors, for instance, like this sport activities, like throwing a disc, then again, like you are going to use a lot of resources that are shared among other functions, behaviors, but they need to be shared. So the concept of the Herc source is that they are able to negotiate the properties of the central nervous system in order to maintain the individual features and prioritize the function. So our central nervous system is extremely plastic, and it's able to readapt constantly to all the experiences and the brain injury like we have to face through our lives. So we know like this, our nervous system is extremely plastic, but after neural injury, it doesn't become so plastic and it loses many of the functions. And through neuromodulation, we'll try to interface this system and try to restore those more physiological rhythms through different tools. Like, for instance, we have neurofeedback, so we can provide information about the brain states, about the state of the muscle contraction, and we can train the subject to receive this neurofeedback and actually change the excitability of given circuits. We have transcranial magnetic stimulation that some of you are working with. We have transcranial direct current stimulation, transcranial alternating current stimulation, that are two different tools that try to change the excitability of the circuits in the brain. We have a spinal cord stimulation in both epidural and transcutaneous modalities. We have direct stimulation of the nerves, or we also have like functional electrical stimulation, which enables to recruit the muscle fibers directly. When we talk about neuromodulation, like I want you like to know, like we talk about acute effect, which is when the changes in the nervous system are happening just while the stimulation is applied, and there's no neuroplasticity because the circuits don't change over time. So once you remove the intervention, the nervous system comes to the previous status. And the best example maybe is deep brain stimulation that is used in Parkinson's disease or tremor management. So you apply some currents in some nucleus in the brain, and that counteracts the symptoms. But the moment you remove it, they can come back. Or epidural spinal cord stimulation, in this case by concocting lab, in which you are walking while the stimulation is on. If you turn it off, your system comes back to normal state. And then we have, which is actually called like plasticity, which is lasting effect, which can be like short-term or prolonged effect, that you measure the effects based to the previous level that can persist 2 minutes. There is not a clear agreement on when you say like it's plasticity. In some statistically, you can say after 30 minutes, if the changes in a given circuit is maintained, you call it a plastic change, but probably after a few hours or day, it will come back because the circuit has not been trained to keep those changes. And then it can be like long-term potentiation, so you can increase the excitability of the circuit, or you can decrease the excitability of the circuit. And like making more excitable is not always good, because we need to know first what's the pathology is about, understand it, and then design our neuromodulation approach. And coming to neuromodulation, like I don't know, remember like in one of the talks, like when we design these interventions and you hope to see like real changes after like 30 minutes of a therapy, it's not fair that after a neural injury, you are actually going to see a real functional outcome, because someone said, like, I think it was Robert Rinier in a talk, that actually it takes you like 2 years to learn how to walk. And the babies and toddlers are kicking all day and trying to learn how the legs behave and when they are walking, they are all day working and they fall down and they get up. So maybe like trying to achieve rehabilitation outcomes in just one session, like it's over ambitious and it's not, of course, feasible. And that's maybe why we fail when designing many studies. Then in terms of stimulation, like think about it, like you can apply many stimulation. By stimulation, it can be vibration, it can be electrotactile sensation, it can be functional electrical stimulation. So you have different interventions that are targeted for different therapies. You can have open loop stimulation, which is, for instance, TENS, transcutaneous electrical nerve like stimulation, in which you just apply a current at 20, 30 hertz and you hope some changes will happen. You have closed loop system in which you actually are modulating your activity based on some input. It can be tremor in this case, that you have some tremor oscillations, these sinusoidal waves, and you will fix the stimulation based on a given phase. Or you can have such a mixture of both, that, for instance, you are not updating the system, but you measure based on the level, for instance, the tremor frequency, and then you set the stimulation at that frequency and see if it will produce any changes acutely or in prolonged. And then we move to operant conditioning. The subject, operant conditioning is when the subject learns to associate a given behavior with a consequence. So it's quite easy. It's the way we learn. It's the way animals learn and everybody. So the spinal cord plays a key role in this and all this role in motor control and learning, and also other structures in the brain, such as the cerebellum, for instance. And the way we learn is because we need feedback. If nobody tells us if we are doing it right or not, we won't be able to actually improve and adapt our movements towards the target we want to do. So that's why I presented everything related to the hexos, wide proprioception, the way we integrate those sensory inputs. It's key in motor learning and actually improve. And also, like brain states and supraspinal input can modulate the spinal reflexes. These preset behaviors that maybe are hardwired at the beginning when you are born, but then they can easily modulate it, and they are modulated all the time during gait or every other task. And I'm going to present the first example. Some of you maybe know about it, is the neuromodulation of the H reflex amplitude proposed by Walpole. And in this case, in a study did by Thompson et al., published a lot of years ago. So this is a research line that took years, starting from animal models and then moving also to humans, in which it's trying to show that you are able to modulate the amplitude of the H reflex. You can upregulate it, so increase the amplitude of the H reflex, or downregulate the amplitude of the H reflex after several repetitions by just providing neurofeedback. And in this case, the neurofeedback is really simple. It's not fancy motor unit analysis. It's just getting the amplitude of the H reflex. So we have here like a typical H reflex plot in which we have the stimulation here. This is done, I don't know, I don't remember, because of the latency. This might be the flexor capri radialis. So you have the M wave, and then you have the H reflex. So you measure the peak to peak amplitude with the EMG, and that's simple. So the protocol consists in having a baseline. You record many of these trials to have a baseline. You have a baseline H reflex amplitude, and then you present the subjects with two paradigms, like you need to actually upregulate it or downregulate it. When you provide the stimulus, like every 5 seconds, for instance, the subject are doing a very weak isometric contraction, and every 5 seconds, you stimulus. You provide a stimulus on the nerve that will produce the H reflex. You measure the peak-to-peak amplitude, and you ask the subject, try to make it larger or try to make it lower. And you provide the feedback, positive feedback, when they were actually able to increase the size or decrease the size. The subjects are not given any instruction about how they should do it. And I think that's the magic happening here. Like, you don't know how you are doing it, but you are able to do it or not. It requires a lot of training, as you can see here. So in red, you have all the subjects that were in all the sessions that were asked to actually upregulate, so increase the size of the H reflex. And you have many subjects that were asked to actually decrease the excitability of the H reflex. And you can see like these were like very time-consuming experiments because it takes like 23 sessions and also a few weeks of follow-up. And it's pretty like clear, like in baseline, the H reflex was stable. When you start training, maybe in the first 2 sessions, 3 sessions, subjects were not able to condition the H reflex, so they are learning how to do it. But at some point, magic happened, and neuromodulation took place, plasticity took place, because they were able to decrease or increase the excitability of the H reflex. They don't know how. They just changed the neuromodulation inputs, like the motor neurons and the afferent fibers were receiving in a voluntary way, but unconscious in the sense that they didn't know how to do it. So they provided like how brain states were measured from the periphery with the H reflex, because you can change the excitability of the H reflex just by changing your way of thinking, and they were able to modulate this input. Now, and also like when the interventions stopped, these changes were kept after a few weeks. So in this case, if we just talk about single session, maybe we cannot talk about plasticity, but here we can talk about neuroplasticity because the changes were kept. But the question is this useful? Like, are neural adaptations specific from the H reflex circuit, like, okay, we can train the circuit with larger reflex. What does it mean? I think now we have the next question. Which is, have the neural adaptation in specific circuits have an impact on actual behaviors? Again, 50% chance. I mean, this is easy. If you think about that, I need to keep talking for 1 hour. Like, you should expect what's the right answer. Congrats. Yes, the adaptation of specific synapses that can be induced to neuromodulation of diseases like can modify the functional behaviors. Otherwise, like I would stop here. So this is the continuation of the previous study in which they tested this in a spinal cord injury patient. So spinal cord injury, like it's a disease in which like most of the fibers sending from the brain like are interrupted, but usually all the lesions are incomplete. Even they can be even labeled as complete spinal cord injury. There's most of the time something residual connecting. So you can still elicit some reflexes in the spinal cord. And in this case, they tested these subjects with a spinal cord injury with the same protocol, but changing something specific. So the previous study was done at rest, subject for resting, doing very slight contraction, and that's it. Here, what they aim is like for instance, in spinal cord injury, patients have hyperreflexia because the afferent fibers in the spinal cord and the motor neurons are not receiving the supraspinal modulation they used to receive. So the reflexes are much larger in amplitude, for instance, in the soleus. And that's one of the reasons like they cannot actually walk, they have spasms and other things. So during gait, the excitability of the stretch reflex in this case changes because you have a cycle of movement in which you have this reciprocal inhibition circuit like working all the time, in which the ankle has to be lifted in the swing phase, so the tibialis is activated, the soleus must be relaxed. If you measure the H reflex in those gait cycles, you see like the size of the H reflex increases or decreases based on the cycle of the day. And this is an example of healthy subjects in which during the stance you have an increased size of the H reflex. During the swing phase, the amplitude decreases. And you can see like some sort of analogous with a cycle gait when doing ankle dorsiflexion and plantar flexion. What happens with the patients with a spinal cord injury is this dashed black line, black line. Like this pattern is not so well kept. And what it happens is that if you are able to actually train and modulate the H reflex in the different specific phases of the gait, you see how the subjects like were able to down-regulate the H reflex. Why down-regulating the H reflex? Because they have hyperreflexia, so you don't want to have like higher H reflex. It's already impaired and causing like abnormal functions. So you want to decrease it. And they also retain their changes not so well for a few weeks, but still the results were significant. And here you can see how that after, like you have more clear pattern close to this one, that the values are closer to the healthy subjects. And most important, I wouldn't care if the H reflex size changes. There were some functional improvements in the gait for these patients. So the neuromodulation and the specific plastic changes that happen in a specific circuit were translated into functional improvement, which is the final goal in all the applications we should be looking at. And also these behaviors like probably were not specific only the H reflex. We are measuring, remember, just a very small window of the whole nervous system. Then I'm going to talk about another application, which are beta oscillations. Dario presented probably beta band in the first talk. So beta band it's comprised of like oscillations, typically measuring the brain between 13, 30, 35 hertz, depending on the classification. And we know they are involved in sensory motor processing. We don't really know the function of it, but we know that it's related to the movement and the way we intend, when we intend to move, how we process the movements, and so on. We also know that this beta band activity is altered in several neurological conditions. In stroke patients, I think Marta presented it yesterday in the presentation, there's a decrease in the event-related desynchronization in a stroke patient. So when you compare both sides, the injured and the not injured side, there are differences in this desynchronization. And it has an implication in the functional outcome because stroke patients can have spasticity, lack of dexterity, and other symptoms. In Parkinson's disease, for instance, it's the opposite. Parkinson's disease is also hypokinetic movement, and increasing beta activity in Parkinson's disease is related to bradykinesia and rigidity mainly. So we have an example here on the left that we have decrease in the beta band in the contralateral motor cortex. And for the controls, if you look at that decrease, while they are doing this movement preparation, the decrease is higher in the beta band compared to the patient, but it seems their beta band is not acting the way it should be. For the Parkinson's patients, this is data from monkeys that it's convenient because you can actually have intracortical, subcortical electrodes, in this case, measuring the local field potentials in the thalamic nucleus. So you can measure the activity there, and when you filter that activity, you have bursting activity in the beta band. So you have some bursts that, when you correlate it to the symptoms they have, you have normal beta activity, but as long as the symptoms increases, the beta band activity increases as well. So this is a correlation between the status of a neural circuit and the symptoms. And this is pretty difficult to measure in humans, but in this case in monkeys, it's a clear correlation. So what can we do about it? How can we use our neural interfaces to actually try to first detect these changes and then act? Probably, I don't know if you've seen this slide. So it's been shown we can decode brain activity from the periphery by measuring the activity of the motor units in the muscle or the neural drive through different systems. Alex is proposing now the activity index, where we hope it goes through and we can avoid the composition limitations, and especially time limitations. So you can record the brain signals from the brain with EEG, non-invasive way. You can record the motor units from the periphery, and it's been shown the neural drive is linearly transmitted to the muscles. When the motor neuron pulls samples, that supraspinal input, it's able to produce the force. But when we're looking at the force, okay, it doesn't tell us much. But when you look at different band frequencies, such as the beta band, different studies have shown that you can actually extract information from the muscles that it's happening at the brain. So we have a non-invasive, more accessible tool that will can maybe bypass some of the limitations and challenges of EEG, especially it's time-consuming, sensitive to noise, and you need very controlled setups. And this is the example of beta band activity, how it can characterize from the muscle, in this case from the high-density EMG. This is the work of two of our students at Imperial College, Emanuele Bagnano and Cosima Greif, working in two parallel studies with different goals. And the applications of this beta band analysis, I'm not going to go deep into it because Dario had a whole presentation about it, and it was very clear. But we have movement augmentation, but it can be used also as a biomarker of disease state of rehabilitation progress. Here on the left, these are results that are under preparation, so they are quite new. And we had full characterization of the beta band across contraction levels for the TA muscle because it gives very good recomposition results, to be honest. We have many units. And we wanted to see how beta band behaves when it's estimated through the CST compared to the raw EMG. And we show when you compute the CST and the EEG, so this is the corticomuscular coherence, and we plot at the same time the intramuscular coherence, this is the CST, so you divide your whole motor neuron pool into two groups, and and then you pick up a random permutation of units, you compute the coherence, you average it, you have an estimation of the intramuscular coherence. And we plot, in this scatter plot, like for the same subjects, this is mixed with all MBC levels going from 10% to 70% MBC. And we have this distribution. It seems like we fit very simple, like logarithmic regression, and we see like how they seem to be correlated. So you can predict with intramuscular coherence, which is a peripheral measurement, what's happening between the brain and the muscle. We tell us like most part of the information from the brain is actually transmitted to the muscle, and the muscle is able to sample it. It doesn't fit linearly, it's not a perfect fit because first, like the data and the estimation of the corticomuscular coherence might not be perfect. We can be missing some units that are important, and we can sample the whole population. And at the same time, it can be, I mean, we cannot rule out that there is a contribution from afferent loops and interneurons that are actually contributing to this intramuscular coherence and are able to adapt the firing patterns of the motor neurons in relation to the inputs from the brain. So this is just one example of how we can use EMG from the periphery to estimate cortical inputs. And then we have this other correlation. This is more challenging. While the TA, we know it's perfect muscle to study. You move to the forearm muscle, you have many muscles. You try to decompose, you have excellent subjects, you have like horrible subjects in terms of the composition, like you get 2 units and you can't do anything about bad crying. So in this case, we have each dot represent a subject with a few trials for 20% MBC of wrist extension. And we measure the burst rate, which coming back to this presentation, like if you measure like the rates or the occurrence of this burst activity when they're above a given threshold, we measure that rate, how it's happening at the brain level, measured with the EEG in one channel. And in the CST, it's called EMG, but it's a CST, and you see like there's a linear correlation. So the rate of the beta projections, beta waves that are projected to the muscle is correlated, also in the upper limb in this case, to the beta waves that are in the brain. So these are 2 examples of applications of how this information points on the goal of COSINA is actually to use this information to see if it can be used as a biomarker to track the effects of the DBS settings. So now the new DBS, deep brain stimulation systems, you can tune up the parameters, you can try to optimize the dose to minimize the tolerance that occurs over time. So this is one potential application of something that we are doing here. This is another example, you saw it, but let's see, we listen to Dario on Monday. So this is based on the work of Jaime Ibanez and also Mario Bracklin in a couple of papers. So we know, as I showed before, like the beta events can be detected in the CST. And this is one example of how this happens. So these are the wavelet transformation of the EEG and the CST. When we zoom in, we have some bursting activity in the beta band here in the EEG, and we also can see like it's correlated to the beta activity in the CST. And we have these correlations between rate that it's going to be confirmed hopefully for the upper limb as well in the extent of radialis and the duration. So now we have some evidence that this is feasible. And now the question is the following. Can subjects learn how to modulate their beta activity with neurofeedback just in a single session? So think about this plasticity concept. If it's feasible to actually modulate and turn your beta in just one single session. 50%. Yes. Okay, so congrats to the winners. Like again, like it's not random distribution this time. I want to just thank Tanya because I sent the questions of the Kahoot for her, and I think she's succeeding in every picture. Like she chose to to go with the Kahoot and the question. So thank you, Tani. So yes, the beta activity can be upregulated or downregulated in one single session. That doesn't mean the changes are plastic, but it's feasible. I hope Dario showed this on Monday because Mario, what they did in this, Mario colleagues in this protocol, they had the EMG from the tibialis anterior, they have real-time decomposition, they have the CST, and they computed like different estimations. In this case, the power of the beta band measured in the CST. And they provided the subjects with the feedback with this beta band power. And they were told, okay, you have to, while you are actually performing the isometric contraction, holding the same contraction level, always stay in the line. You need to try to upregulate on the regulate beta. Why is it possible? Because beta band does not have an effect in the production of force, at least in the conditions we are testing. And it's been shown also other like simulation and experimental data. And what happened is that subjects need to be trained, of course, and it's something difficult to achieve. Not everybody can do it, but when you measure the power of the beta band for the subjects that were told to downregulate it or upregulate it, they were able to actually see changes between these two groups. And these changes were significant both in the CST, so they modulated the neural drive transmitted to the muscles, measured in the EMG, but also when looking at the EEG, those changes were also significant. And also they were significant for the EMG for different, like the amplitude of the beta bar, the duration of the rate, not so for the EEG. So it was very challenging, but healthy subjects were able to modulate the supraspinal input into the alpha motor neurons in the beta band while they performed, and they were able to keep the same performance while executing the task. And I think this is a key aspect that one of the applications in this case for movement augmentation, or even it can be used for rehabilitation. For instance, if you have patients with Parkinson's disease, why not, and they have upregulated beta band that is correlated with some symptoms, like why not trying to see if you can have some non-invasive method to actually train them in able to decrease that beta activity and see if actually correlates to functional improvements. The next example I'm going to talk about, it's like human machine interfaces that will use some information from the brain or the muscles in this case, and we will close the loop with the stimulation. In this case, we need to start from the paired associative protocol, associative stimulation protocol, created by Stefan et al., in which you have very simple setup, in which you have the TMS, so you are able to activate the brain in the motor cortex, that when you do it, you can actually elicit action potentials in the target muscle, and this is called MEP, like action motor evoke potential. This is direct activation of the motor neurons from the brain to the muscle. And you can have this baseline assessment that gives you an estimation of your corticospinal excitability. So you do it, and at the same, then during the intervention, what you can do is actually provide the same stimulus, but at the same time, you will stimulate, in this case, the median nerve here at the wrist, and you select very specific stimulus timings that will make this stimulus to arrive at the motor cortex more or less, or not more or less, with millisecond accuracy in the same synapse. So what you are trying to reproduce here is this Hebbian principle we talked about before. Like we try to converge two stimulus at the same time in the same region, in the same circuit. So we will promote plasticity and some changes in the circuit. So after a lot of pairing, and 90 is not a lot, like it's an easygoing protocol. We've done like protocols with hundreds of stimulation. So you can induce plasticity. And this is what they found in this study like 24 years ago. Some of you probably were not born, which is scary for me at this time, but I'm very old. You have an increase on the MEP side. So by just pairing the stimulation at the right timing, you increase the corticospinal excitability. If you change this timing to a different one, the changes won't happen because plasticity is not taking place because the conditions are not met of time synchrony. So how we can actually exploit this? So can be used to increase the excitability of the circuit that, for instance, in a stroke can be impaired. And this is the goal of the work done by Makaras Kerstin. I don't know how to pronounce it. And this is done with the movement-related cortical potential. So they were described by Miguel Angel and Marta and many other people talking about EEG before. So when you are imagining or you are planning to perform a movement, if you finally execute it, you can measure like these brain waves that there's a decrease in the amplitude, and more or less right before the execution of the movement, you have a peak, and then when the movement is released, you have an increase in the power. So you can measure this potential in the subjects and calculate like this peak in respect to the cue you gave to the subject in order to perform the movement. So the whole experiment is like you have MEPs at baseline, so you have your baseline condition, corticospinal excitability. Then what you can do is actually train the subject to get this MRCP. You estimate this latency compared to the cue. You program the stimulation of, for instance, in this case, the target is the tibialis muscle, and you stimulate the common peroneal nerve. And you provide some stimulation in two different conditions. So maybe around this negative peak, or the different stimulation right after or right before. So, but not so concentrated about the peak. And what they show is, let's see if you can guess what are the results and when it's the right time to actually stimulate and induce some plastic changes. So the question is, at which time point will the stimulation induce changes in corticospinal excitability? Oh, I increase the difficulty with 4 answers. I need to ask, like, who is the fortunate, who is the lucky one? Yeah, I have to say, like this work was like followed by Jaime Ibanez at all, and we have a few of his students here, and I only see one correct answer. So the question is, like, if we go back, the changes happen when you synchronize the stimulation. I think it was plus minus 25 milliseconds around the negative peak of the MRCP. So this is what happened. When you actually provide the stimulation at that specific time, when you measure the corticospinal excitability, measure with the peak-to-peak amplitude of the motor evoked potential at different intensities, you have like this black lines, dots are the baseline, but the triangular ones is 30 minutes after the intervention. So you can see an increase in the corticospinal excitability when you choose the right timing. In the lower plot, when you choose like random time is like more than 25 milliseconds after the cue was presented, or 25 milliseconds before the cue was presented, then you have no changes in corticospinal excitability. So the timing matters. And one application about this is that you can do it also like with motor imagery. So you don't need any residual activity, and it could be applied, for instance, in a stroke or other diseases. This is another example, a very old project I was involved in, in which it's the same principle of using the paradigm I just presented, but we made it like more complex, because sometimes you think you will sell more, but sometimes it just makes things more complex, and it's difficult to actually synchronize everything and make sure it's working. So we had this motor related cortical potential with the measure with EEG, and at the same time, instead of just providing just one single fluid in the tibial nerve, this was aiming to improve like the reaching movement in these subjects that had a stroke. And we use, on the one hand, an assistive device. This is our Mayo Spring. It's an exoskeleton. It's passive, so it supports your body weight. And if you have some movement difficulty, it allows you to perform the movement easily because you don't have to compensate for the weight of your arm. And at the same time, instead of just stimulating one nerve, we applied like FES. So let's assist the movement as well. And that assistance was synchronized with the movement-related cortical potential. And this is just a case study. At the end, like we discontinued the study for several reasons. But for some of the subjects, like we had a very few, but this is a very good example of how the subject actually progressed. And when looking at the MEPs, they were increased after just one single session and for the right protocol. And the range of movement in the arm and the shoulder like increased after like 4 weeks of training. But every time you look at this is a case study, but every time you look at these studies in which you have one very nice experimental condition, you should always expect to see a control condition. In this case, we hadn't, but I guess like who knows if just the changes we are seeing, it's just because, for instance, in the functional outcomes, just the subject was doing some more rehabilitation and it was the natural flow to progress. Next step, like we can use EEG to predict brain states, but maybe we can use EMG, which is not such a pain in terms of setup. And in this case, it was just even like bipolar EMG. So we have the same protocol, we have the subjects that are instructed to rest, then you have a target, like get ready, 3, 2, 1, move at this point. And you have to move your FDI muscle. And in this case, instead of using the EEG to have some cortical potentials, we will use just the EMG and the motor response. So you can measure the reaction time based on the EEG. It's the most accurate way to measure the response time. Based on the delay in their response, average delay after a few trials, you can set different stimulation protocols. Let's focus just on this one, like stimulate 30 milliseconds before the movement actually happened, 30 milliseconds after, just at the same time, 15 milliseconds after, or like something different. And of course, what happened is that the stimulation, when it's delivered before the movement happened, which is more or less at the same time this negative peak of the MRCP is also taking place, even if you are not measuring it, you can see like there's an increase between the pre, post, and post 15 minutes condition. In this case, like plasticity was defined to happen after 15 minutes, but guess no, who knows if actually these changes were kept after this time. So in this case, EMG was used reaction time as a surrogate of the brain states and the CVN, there's a typo there. So you can avoid limitations of training with EEG, the mental fatigue that maybe you can discuss on subjects that they don't have clear potentials and the EEG setup. And what I want to highlight here is, again, like the timing in providing your stimulation and aiming at your neuromodulation protocol, it's a key factor. Just by changing by a few milliseconds, everything can go completely like messy. So let's continue. I think you've been lucky. I've been told to speed up, so we can go to it flash. Now I'm going to talk about the second part, which it's more my main research line, what I did in my PhD and what I've been continuing doing at Imperial with Dario. Pathological tremor. Like these are oscillatory involuntary movements of one or more body parts, typically between 3 and 12 hertz. And you can see an example of someone who is trying to do this is a common clinical test to evaluate the degree of the tremor, and subjects cannot perform the movement. It seems quite, I'm going to say, silly condition because you are trembling, you are not going to die of it. But these people have really like sometimes poor quality of life because they cannot drink from a glass, they need a straw because they feel like people will stare at them, they prefer to stay at home, sometimes like they develop depression. So it's something really hampering, like now with the phones, like they cannot type because when they hold it, like it's shaking and they cannot aim for anything. So it's something quite serious and affecting a lot of people, mostly when you age, and even young people like can have it. It can be caused by several disorders, essential tremor, Parkinson's disease, when you have a stroke, for instance, or any kind of neural injury, you can have developed cerebral ataxias and they have tremor. You can have dystonia that also caused with dystonic tremor in multiple sclerosis. So there are many diseases causing this tremor. I want to make the difference between Parkinson's disease and essential tremor. So they are different. And when you see someone trembling, maybe they don't have Parkinson's disease, maybe they have essential tremor. Essential tremor is not so known. Let's start with Parkinson's disease. It's a neurodegenerative disease caused by gradual loss of dopaminergic cells in the substantia nigra, in the basal ganglia. So at the end, you have cells dying in your brain that cause a lot of motor symptoms, tremor, mainly at rest, and that's the main difference. But you also have bradykinesia. These people find very difficult to perform movements, and they're very slow. Even they try to do it fast. They have muscle rigidity, which also helps to not able to move as they want. They develop postural instability, freezing of gait, which is something like they are walking, and at some point they cannot do the next step, and they are just freezed. It's quite interesting, but they have to develop some mental tricks to unlock their brain so they can actually keep walking. And they also have non-motor symptoms such as dementia, cognitive changes. There is no cure available. The main treatment is levodopa. And then you have different options. For instance, if you have tremor, you can have botulinum toxin injected in the muscle to prevent the tremor happening. You have physical exercise. Maybe it's the first treatment it's prescribed because it's been shown it actually helps a lot in mitigating the symptoms, especially if you can start early when you develop the tremor. And the best treatment is deep brain stimulation, which it's also one of maybe the most extended neural interface actually stimulating the brain and achieving really good results. Then we have, on the other hand, essential tremor, which is a disease affecting it's not a disease because it's not properly understood how it works. It's a syndrome. It affects 4 to 5% of the population above 65 years old. So when you grow up, you see many people have tremor. If it's not Parkinson's and nothing else, they label it as essential tremor. Again, there's no treatment for them. Pharmacotherapy is the first line of treatment, but they are strong medications and they develop some side effects, so many people don't take them. Alcohol works while you are taking alcohol. The following day, it doesn't help that much, and at the end, your liver won't be very happy about it. Then you have, again, botulinum toxin, DBS, high-intensity focus ultrasound, which is more or less recent technique. It's a thalatomy, so they basically, with ultrasound, burn and completely destroy one of the main nucleus involved in generating the tremor oscillations. So that helps a lot, and the tremor is cured, at least for a few years, but also you are destroying a part of your brain, probably was doing something else. So not everyone wants to risk it. And as I said, it's a disabled condition. Now, question time. I hope you didn't close it. Well done, Marcos. So, this is the previous one. Should I give you the chance to? Let's skip it. I don't have the time. Sorry. Okay. So. Okay. So now, select the correct statement. Is tremor only driven by inputs from the brain transmitted to the muscles, or you think the spinal cord, the afferent loops play a role in tremor? I think you have a few clues after my presentation about the role of afferent fibers and everything else. Okay, so congrats this time. And so yes, the main problem is happening at the brain. So you have something that is not working properly. You have some aberrant malfunctioning circuits in the cerebral thalamocortical loop. In the Parkinson's disease is very well characterized where the tremor is coming from, but this propagates to the muscles, to the alpha motor neurons, but we are missing a whole set of interneurons, afferent fibers that are actually contributing and enhancing those loops to take place. And we don't know much about them. And how we know like these centers are involved. First, because there are many treatments that are targeting afferent fibers, stimulation, sensory stimulation, even acupuncture. And you see that like for some people it works somehow. So somehow the afferent loops are embedded in the terminal network. The DBS, like it's the best treatment you have to mitigate the tremor. It's not going to cure it, but you have a stimulation of subcortical regions, depending on the type of tremor. If it's Parkinsonian or essential tremor, you target different regions. And it's the best option you can have. Just to highlight, like having some sort of implant that it was started to be commercialized in 1987. Like it's not something new. And actually, from the 1936, there was just some studies showing like invasive stimulation of the brain, in this case in epilepsy, did have some effect in mitigating the symptoms of neural diseases. So this is a long path, but finally, like we have procedures that they are safe and it can be tested in many patients. So this is how DBS look like. You have it's intracortical because it goes to the cortex, but you are actually stimulating like some centers in the basal ganglia, the thalamus, and it's a very complex surgery, but very well controlled. So you have the electrode, you have a lead, and then you have like a pulse generator, just like a pacemaker. Basically, it's the same technology used. And the mechanism of how this works is not very well understood, but we know it works, and now there are more studies showing like how it disrupts these aberrant rhythms. But it's limited. Its application is limited because not everybody is willing to go to a surgery when you are of a certain age, and even the doctors won't recommend it. So what you can do with DBS apart of like just mitigating? So it's a very nice tool because you have direct stimulation of subcortical brain centers, and even like the new settings can record from it. So this is an example by Kanyan, like in which also like exists now in Imperial College London, that when you stimulate at the tremor frequency for that specific patients, there is something happen that it's called entrainment. So the tremor signals propagated from the brain to the muscles actually follow the stimulation that was delivered at a given phase. So this is frequency lock, not phase lock. And still what it happened is that when you look at the tremor phase synchronized with the stimulation, you can see, and this is the change in tremor amplitude, like some phases reduces the tremor, some phases increases the tremor. So when you provide just a calibrated open loop, frequency locked stimulation, it seems like the brain is able to adapt to that stimulation. And when it adapts, sometimes it does it with a certain phase that reduces tremor, and sometimes with a given phase that increases tremor. When you do the same experiment, but you stimulate instead of the tremor frequency plus minus 2 hertz, or plus 2 hertz in this case, you see like this is the red dots, like these changes in tremor suppression are not so high. So in tremor amplification, again, it's not so high. So the changes are not happening when you don't select the right frequency that is actually entraining the circuits. So frequency matters in this case. And this is another example of how you can use EMG to characterize tremor. You have your wrist tremor. It's moving that leads like flexors and extensors of the wrist, flexor carpi radialis, extensor carpi radialis. And you have one afferent fibers like playing this role in reciprocal inhibition. When one muscle is activated, it will try to inhibit the antagonist one. If you are doing voluntary movement, this is something good and desirable. But when it's an involuntary movement, maybe it's not that good because it's fibrin tremor. And it was shown, like, for instance, in essential tremor, when they are holding this posture, like the pattern activation for these muscles, like it's called out of phase. So when the extensor is active, the flexor is not. The next tremor cycle, it's the opposite. So they are alternating. Is this always true? No. Juan Gallego in a couple of studies. I think even Hallis and Silvia were around these times. So they show like the relative phase difference between the neural drive transmitted to the muscle in a couple of antagonist muscle, flexor and extensor, is associated with the change of supraspinal and afferent input. And the key thing is that they also have some computational models showing like when you have like this tremor propagated to the muscles, if you change the voluntary input and afferent fibers start to like be engaged, you have different in the phase between these two muscles. So for instance, at rest, when patients have tremor at rest, both flexors and extensors are more or less in phase. So projections, tremor projections arrive at the same time in the muscles. When you go to the posture, so there's some voluntary engagement, you change the excitability of the motor units, you change the properties of the afferent loops, this moved from in phase to out of phase. And how we can exploit this? So we did a study, in this case it was a few years during my PhD, in which we asked healthy subjects to mimic tremor for 20 minutes. It was strange, but people were able to do it. And you have the EMG measured with bipolar electrodes. In this case, for the intervention, and we set like 2 interventions of 20 minutes in which we applied out-of-phase stimulation. So the stimulation was delivered out of phase with the extensor carpi radialis activity. So when the muscle is not active, we stimulate the radial nerve, the one innervates that muscle, below the motor threshold, so just recruiting sensory fibers. And we have another group in which we stimulated in phase. The subjects underwent like 2 conditions in different weeks. And we have like a closed loop algorithm measuring the root mean square of the EMG and adapting the response to the tremor and synchronizing the activity, the stimulation with the tremor activity, mimic tremor activity in this case. And the question, I think this is difficult unless you've written the paper, you've read the paper. So which will be the effect of this intervention? In phase stimulation increases group 1 dysynaptic inhibition. This is reciprocal inhibition named at the wrist level. Out of phase stimulation increases this reciprocal inhibition, or there are no neural adaptations achieved in one single neuromodulation session. I'm going to say like this is red. So the results we show is that in-phase stimulation increased this reciprocal inhibition. We show it for the wrist, and it's been shown like it's also true for other circuits. So what we did to assess this reciprocal inhibition is having the H reflex. And we can have like the reciprocal inhibition measuring the H reflex. When you condition the H reflex with a stimulation of the antagonist 1A fibers, you have a decrease in the H reflex. So this is the difference between the red and the blue line. So the blue is the conditioned H reflex, this is smaller, so that difference is the reciprocal inhibition. And we measure it in the flexor carpi radialis. And what we show is that after intervention for the in-phase protocol, this difference was increased. So let's look at this one here, it's easy to read. So after intervention in phase, just immediately after, the change in group 1 inhibition was decreased. So this is the size of the H reflex. So this inactive group 1 inhibition, reciprocal inhibition, it's easier for you maybe, increases after SATs in phase. SATs is the closed loop algorithm. So, and for the out of phase, we have the opposite effect. It decreases. So by just having 2 different phases for the stimulation, we achieve opposite effects in a given circuit. And this is important because whatever intervention you have to design, you need to understand what actually are your effects. And this is what we try to do later, and what Dario did in the past with dosing antidiuretic in a couple of papers. So they propose this out-of-phase stimulation in which you have like a pair of agonist-antagonist muscle. We always focus on the wrist, it's easy. And to measure the surface EMG, and you have this out-of-phase activity between both of them. And then you can predict when the tremor cycles will happen because when you stimulate, you have a stimulation artifact and the EMG quality can be completely gone. And then you can set the stimulation for a few tremor cycles and stimulate out of phase, trying to engage this reciprocal inhibition. And later we developed more adaptive algorithm, very basic, in order to also consider if there is also in phase activation. We would also consider, because we are not predicting, just recording in short windows. And this is the application. We tested in the Extend project. We had 11 patients, at the end 9 selected for analysis with enough tremor. We had one session with intramuscular stimulation that presumably would allow us to stimulate just the 1E fibers. And we have another session with surface stimulation. We have a closed loop system working in some of the session, and another condition called continuous stimulation. In this case was 2 seconds of stimulation at 100 Hertz, no closed loop, nothing, completely down the stimulation as a control. And we measured acute and the short-term effects with kinematics and also clinical scales. But I will just show the overall session for each study. So we have an intramuscular or a surface session. We measure the baseline levels. We have different trials in which the subjects were asked to hold a posture. We stimulated on, we turn on off the stimulation in 30 seconds window to see the acute effect. And at the end of the intervention, we measure the post effects. These are the stimulation electrodes we use. They're called thin film electrodes. Sylvia will talk more about it tomorrow. And then we have the surface electrodes placed on the nerve. This is a video of the whole procedure. So it's some sort of TV commercial, before and after. We have the patient trembling. And how did we do this? So on the one hand, we did the insertion of the intramuscular electrodes made by the physician with ultrasound. We identified the flexor carpi-radialis, extensor carpi-radialis. And as you can see the needle going through. No, that's the needle going through. It seems painful, but the patients actually reported out of 10, a pain of 2 on average. So it's not painful. We are always grateful to them because they are really nice, willing to help whatever the conditions and the length of the experiments. So those electrodes have EMG recording points and stimulation points. So it allows a full closed loop neural interface. We recorded the EMG. We selected the best channel to measure the tremor. And then we have an embedded system, recording the EMG and having this closed loop stimulation system based on the tremor amplitude. If there's no tremor, it shouldn't stimulate. We were looking for the acute effects, that's the truth. But we were surprised that for many patients, there were an after effect more pronounced than the acute effect. It's very difficult to draw conclusions in a small cohort of patients, but some of the results like really nice. So these are the acute effects results. This is an example of the pre, the post, so the tremor amplitude measured with kinematics is reduced. And the acute effects were quite subtle, but let's focus just on this one. At the wrist, we measure the contralateral side to see if there were changes. It seems there are no changes in the contralateral sides. And most of the time, the tremor was mostly reduced there, so there was nothing to target. But the red line is the condition in which we stimulate with intramuscular electrodes with the closed loop system. This one, the lighter red, is I don't remember, it's been a long time, the closed loop system with the surface electrodes, and these ones are the continuous stimulation, random stimulation. So we can see when measuring the acute effects, while the stimulation was turned on or off, was reduced, positive values about 0.5 means tremor reduction, and on percentage, this was around, on average, 32% tremor reduction while the stimulation was applied, and the N was 9 subjects, I think. So it kind of works. It's aligned with results from previous studies. But what's more interesting is that we have an effect on the stimulation condition, but when we measure the stimulation after, the effect afterwards, we started with 4 patients in which we have the out-of-phase stimulation and the continuous stimulation, different trials in the same session. Then we figure out they're improving after the session. Maybe let's just get rid of testing both of them. We know the acute effect is around, and let's just stimulate with the out-of-phase stimulation and or the continuous stimulation. So The continuous stimulation never achieved any results. There are few patients, but it didn't seem to work. While when the patients received this closed loop stimulation, there seems to be an effect in thermal reduction. So these results are not conclusive, but it's giving us like good insight in that closed loop, or at least targeting spinal circuits at the right timing, like it's important in actually dealing with movement disorders. Then how we can improve this closed loop system? So with high density EMG, why not? So we can record the EMG activity with reads from flexors and extensors, and having a PLL system like to detect the phase of the tremor in real time when you have the CST, and you, instead of using surface EMG, which is affected by crosstalk, and that's a problem in the forearm, that's for sure. Like you can have crosstalk from many adjacent muscles. So with the CST, like crosstalk is reduced, and maybe you can provide like more accurate in-phase stimulation. And this was tested in Darius' lab by Putoraxa a couple of years ago. Then what else we can do? We also like had the kinematics during all these trials, and I said like, let's try to see if instead of just using this real-time algorithm, we can actually predict and have a tool for predict for longer periods of stimulation, or see if we can predict the next tremor cycle with enough accuracy to just deliver the stimulation at the right time. So we tried some long short-term memory neural networks, LSTMs, with the kinematics, and we also have the data like ready for the EMG. And it seems like these networks also very simple, like they can predict very well the tremor cycle. So tremor is, if you look it in the long windows, it's non-stationary. The tremor, we are not a perfect clock, so the tremor actually changes phase. Frequency is more or less stable, but the phases will change, the amplitude will change. But when you look at very short windows, the neural networks were able to predict the next tremor cycle, both in amplitude, so you could even adapt the stimulation amplitude, something we were not doing before. And then we move to like other non-invasive stimulation modality, which is transcranial electrical stimulation of the cerebellum. Looks scary because you have to put one electrode here on the forehead, one electrode on the cerebellum, and you apply like very low current electrical stimulation. This was done by Schwellman in a good paper. This is the question. So they did this for essential tremor patients. And what kind of results do you think they got? So among all the protocols they tested, which there are two, the frequency locked, the open loop actually reduced tremor acutely in a statistically significant way. The phase lock, the closed loop, none of them, because it's like non-invasive stimulation, or maybe both of them worked. Blue one. So the phase lock protocol worked better. Let's see the results. So they had these two groups, like closed loop and open loop. Top row is like open loop, calibrated reduction of frequency, but this is the closed loop, locked to the phase of the tremor measure with the acceleration. And actually, if you see the results of the closed loop, they split the patients in patients that have significant tremor reduction, which are the blue lines. So they have 8 patients with significantly the tremor was reduced, 3 patients the tremor was increased. And when you split them, you can see very nicely, like for the ones that work, it really worked. For the ones that didn't work, it didn't work very well. For the open loop, we have more variable results. You kind of see the same trend. Maybe for some of them work, but there's much more variability. So in this case, like having closed loop system help in reducing the tremor. And we say, okay, that's cerebellar stimulation. It's quite peculiar protocol, maybe not suitable for everyone. And we can try transcutaneous spinal cord stimulation. So we stimulate the spinal cord with electrodes in the region we aim to target. So in this case was C6, trying to target like most of the forearm muscles. And we tested different stimulation frequencies because this was the first time it was done. So we need to have some exploratory effect. So we had like 1 Hz stimulation, which was shown in previous studies with peripheral nerve that it somehow reset the tremor. We have this open loop stimulation lock at the tremor frequency. We have stimulation at 21 Hz, and like what happens if we stimulate around beta band? We like beta band. So let's see what happens. The results are almost accepted. And again, question: which transcutaneous spinal cord stimulation protocol actually disrupted the tremor? To 1 Hz, stimulation at the tremor frequency, 21 Hz, or we have also had, forgot to mention, a control condition, the trapezius stimulation. Please don't select the green one. Well done. So the tremor frequency worked better. And so yes, the stimulation, transcutaneous spinal cord stimulation, it's assumed to, and it's been shown to recruit the afferent fibers and interneurons in the spinal cord. So we set the stimulation intensity that doesn't recruit the motor neurons directly, and the transcutaneous spinal cord stimulation can't unless you have used insane intensity. But we show like the stimulation locked to the tremor frequency reduce the tremor. So this is the timeline, all the trials and subjects average. And we can see how when we provide the stimulation at the tremor frequency, after 20, 30 seconds, you can see how the tremor was reduced. And these results were statistically significant. When we separate the results based on like subjects that were responsive, non-responsive, like 11 out of 18 subjects actually showed this tremor reduction. There were a couple of them that the tremor went crazy because not everyone likes the stimulation. That should be true. And the average tremor reduction on percentage compared to the baseline levels was around 25% while the stimulation was applied. Here, there are no acute, plastic effects at all. And also, what's also interesting and related to the DBS study I showed you before is that when we look at the phase relationship between the stimulation and the tremor measured with the kinematics, many subjects didn't show any relationship, but some subjects, like this one, 7.2, they show like this, what we call before entrainment. Actually, everything here measured with the phase locking value above the significant threshold was actually what we call entrainment. So these subjects, their tremor follow the stimulation pattern. And for most of them, the tremor didn't get worse, but it kind of improved. So these are interesting results we didn't really know how to explain, but they are aligned in the sense that this afferent stimulation can actually have a role in guiding tremor. And this is the final, I'll do it in a few minutes, about neural interfaces, and we can study spinal circuits. I'm sorry for a few faces that I've seen the presentation in Isaac and also motor neuron meeting. So when we have like a neural disease, we know like there's something that is not working, and we can understand how these changes in neural disease happen by studying the spinal circuits through the EMG. And that can allow us to monitor disease progression. ALS patients like amyotrophic lateral sclerosis, and it's a neurodegenerative, like lethal disease. And for instance, the cutaneous impurity is a circuit that is affected in this disease. So the latency of the inhibition when you measure the circuits, it's higher for the most severe cases. And the studies were done most of the time with surface EMG or needle EMG that allows you to have 1, 2, maybe 3 units if you are lucky. Frequent inhibition is also altered in this patient. Reciprocal inhibition is altered in Parkinson's disease. We have hyperreflexia in spinal cord injury. So we have a lot of diseases in which the circuits measured in the spinal cord through EMG and reflexes can be studied. But the truth is that most of these studies were done in the 90s, early 2000s, and they were discontinued. So neurophysiology was not very trendy. they found some changes, but everything stopped there. Everything was measured with test reflexes while subjects were most of the time at rest. So it didn't give like much information about the real excitability of the motor neurons and the reflexes and the afferent fibers and so on. So I think I can go like very quickly over this. EMG, surface EMG is good for some things, but internal and muscular EMG, like it's invasive, but we have high density EMG. It's the best one in the world, but it's challenging because it's time consuming. And it doesn't have been used in many real applications. And that's one of the limitations. Like we have a lot of studies in research environment, but when it comes to translation to the clinics, something is prevented to actually giving value for the clinicians, the patients, and the treatments or monitoring tools. So we have this study in which we try to characterize the spinal circuits with high density EMG, and we aim to measure like the properties of individual motor neurons or latency or duration of the inhibition in just single motor unit, because before we had the needle, so we have access to just one unit, but with high density EMG, we can look at the population level. This is the cutaneous allen period circuit. The subjects were doing some pinching. We measured the FDI, also the APB, not shown here. And when you provide a like nociceptive, that means painful stimulus in the pinky, so that recruits the A delta fibers, measuring pain, goes to the spinal cord through through an inhibitory interneuron. It will inhibit the activity of the alpha motor neurons of the FDI. It's a withdrawal reflex. So if you have some pain in the pinky, like while you are pinching, like your natural reflex will be release. This is dangerous. And this is altered in ALS patients, and it's been shown with needles. So instead of using needles, let's use high density EMG. Tested in a few healthy subjects, we're increasing the cohort. So we have the motor, the EMG with the composed. We corrected the shift for the motor unit action potential onset, and we removed some outliers because we have very long recordings, like 5-minute recordings. In the FDI, it might be fine if you have 10 units, but we also did this for the TA. So if we have to edit 5-minute recordings for the TA with 40 units, and we need to edit all of them for 5 minutes, I would be dead and I wouldn't have finished. So we just removed the outliers, hoping that we have an averaging method and will compensate and allow us to see the results we want to see by compensating for the errors. And with this, firing rates and spike trains, we build the both stimulus time histograms and frequency grams. I'm going to explain very quickly here. So we have spike train, 1 unit. In orange, it's the stimulation triggers. If you have N stimulus, in this case was around 160 per child, what you can do is like sum all of them, you build up a histogram, and then with the histogram, you can have the cumulative sum of the occurrence of the spikes. And this is a measure of the increase or decrease of the occurrence of the firing. So if there is an increase in this orange line, the Q-sum, you have an excitation. If you have a decrease, you have an inhibition. This is cutaneous allen period, silent means inhibition. So we can see like around here, we can see how the motor neurons, this motor neuron stop firing. You have very few firings, and then after 100 milliseconds or so, it stops firing again. You have an increase in excitability, firing rate, because the inhibition was over, so the motor neuron tried to fire more or less always at the same time. So why this is useful? So because we can have, these are just 4 units among probably 8, 10 for the same subjects for the FDI. And we have these beautiful inhibition profiles in which you can measure the latency. You use the post-stimulus time histogram to detect the start of the inhibition because that's the occurrence. But previous studies have shown like actually for measuring the duration of the inhibition, it's better to use instead of the occurrence, like the change in frequency, which is slightly delayed. So it's more sensitive to measure PSF, which is a stimulus frequency gram. It's more sensitive to measure duration of inhibition. So by taking the start in the PSTH, the end on the PSF, we can have the duration for individual motor units or many motor units for the same subjects. Why this is useful? I will skip this one. Because these are results published with ALS patient and healthy subjects
you have 8 healthy subjects, just a few units. It seems there's a correlation between the discharge rate of the identified units with the needle EMG and the PSF duration, so the inhibition duration, which means like the higher the discharge rate, the lower the inhibition, the shorter the inhibition. And this correlation seems when you have ALS patients is not well kept. And what we show, like these are just 8 subjects. We need to do like more cleaning of some units, even we're not even, but making sure they are good. And this correlation of a week, it's preserved, such as here. But we are missing motor units from different subjects in the same plot. Is that the right way to proceed? Maybe not. And when you look at the individual data for the individual subjects, you can see how, except for a couple of subjects, the R-square values of the regressions like improve dramatically, and also the significance. And you can even, you have very few units for some subjects, you can see like clear trends showing that there's a relationship in the firing rate and the inhibition duration. And what's the potential application of this? Like maybe like these correlations, when you have a disease such as ALS, is lost. And maybe like this happens before you actually develop the symptoms. So it can be used a potential biomarker as an earlier diagnosis, we don't know, but also to monitor the progress of the disease. Another example, just aligned with the results I showed, reciprocal inhibition in the TA. So you stimulate the afferent fibers from the solio in the tibial nerve. It will go through the spinal cord, one inhibitory interneuron, and inhibit the alpha motor neurons of the tibialis. We have this 5 minutes recording at 10% MVC, 150 pulses, more or less, of the grids of units, depending on the subjects. And this is the results we get. Like we have some units, because the stimulation is so set to like very limit intensity to low intensity to elicit the inhibition, but not produce like strong artifacts or waves that can contaminate the EMG through the crosstalk. So we have units like this one on the left, like there's no increase or decrease in the occurrence or the firing rate. This is increased, but it's quite noisy. So this, we don't consider this inhibition can be actually counted as one. But we have very clear inhibitions like here, both in PSTH and PSF, and we can characterize this inhibition duration for this circuit. And this is just one subject. So the same relationship we saw before, it's also kept here, like between firing rate and inhibition duration. And when you look at the units from 2 different subjects, for instance, here you have the cutaneous silent period for this subject is the FDI. They have most of the time a slightly higher discharge rate compared to the TA. And then we have the units from the TA reciprocal inhibition. We can see how they are clearly differentiable. So the method is sensitive to detect different inhibitory circuits, even though they might share like the same inhibition duration, discharge rate. The inhibition duration is different, so the method is sensitive, So this is just one example of one application of a neural interface that can be used for monitoring, but also maybe could embed it in some other like neuromodulation approach. So the final home, take-home message I want to deliver is that through neuromodulation, in all this field, we try to modulate this neural activity and try to restore the physiological rhythms that are affecting neural disorders, Parkinson's, essential tremor, dystonia, after a stroke, cerebellar ataxias, whatever. And the key thing first is understanding the disease, and maybe we're not very good at this. So we need to understand what's wrong. Once we identify what's wrong, we can design the paradigms that are actually decrease the excitability and try to make like something that makes sense, not just let's try stimulation and see what happens. Usually it's the way we proceed, but it's not the good way to have results, less with non-invasive interventions. So you provide the target neuromodulation protocol, and then you look for functional recovery, like electrophysiological measurements by their own that are not followed by functional recovery are interesting for science, but not for the patients. And the other application, a part of movement augmentation, it's diagnosis and monitoring of biomarkers to understand the pathophysiology of the disease. So I want to thank all the people I've worked with. Probably I missed a lot of people this year, so thank you very much.